Well, it's really a pleasure and honor to be involved in this program, to talk to you today. I want to give I sort of a lot of agenda items here. I want to kind of give you a few different things here. That's the outline of the talk. And by the way, those of you who are interested in getting any copy of these slides, I'm more than happy to share anything that doesn't have patient data on it. So I'm more than happy to share that with you later. So feel free not to take notes or connect through Beth or however you want to do it. So happy to share all the information. So anyways, I want to talk about essential tremor. I want to talk about the most common procedure that we've had for a long time called deep brain stimulation, and then this more recent procedure, MR-Guided Focused Ultrasound, and give some examples of patients that we have treated at our center. I'll give you an idea of the outcome studies. I don't want to get bogged down in statistics, but we can, and I'm happy to provide more of that later. And then also mentioning the other condition, Parkinson's disease with Tremor-Dominant Parkinson's, that it's been used for. And then we can get into some frequently discussed questions about how to optimize treatment of tremor. And then we have a very kind person who has offered to talk about their experience recently at our center with treatment. So we'll get to that later. And then discussion together, okay? So, and by the way, those of you who are running things from the back, if I get too slow and bogged down, just start waving your arms and I'll go faster, okay? So let's start with a brief discussion of essential tremor. So essential tremor is actually, and this is still quite remarkable to me, it's not well understood in the public who thinks about Parkinson's and Alzheimer's and all these other things, which are very important conditions. But it's actually the single most common movement disorder. And it can have, of course, a variety of severities, but it's quite common. And it can affect up to 4 to 5% of the population, which is quite a lot of people. Both genders are affected. It used to be called benign essential tremor. The thing is, it's not benign because at some point it becomes severe enough that it interferes with daily living. And to me, that is not benign. Some of the characteristics of the tremor, it progresses slowly in most people. There can be a family predominance. Many of you probably know that essential tremor can run in families. But when it gets severe, the tremor can interfere with activities of daily living. And severely affected patients have trouble with really many activities, such as feeding and dressing, and just anything related to fine motor activity of the hand. In most patients, the tremor involves just the arms, although it can also involve and progress to involve what we call midline tremors, head, jaw, and even voice tremor. And that's an interesting discussion of how to treat tremor of the hand versus tremor of the head, for example. And this tremor is what we call a kinetic or action tremor. So there's actually very interestingly different types of tremor that we see in people. And in this case, it typically begins as an action tremor, meaning as someone is actually doing something, the tremor comes out, particularly at the end of the movement. For example, when you're trying to write or you're trying to hold a spoon to drink some soup, and you can imagine how difficult that can be. Any type of fine motor activity can be affected. It's different than most cases of Parkinson's tremor, where the tremor is more of what we call a rest tremor or resting tremor. So that's a very different type of tremor. There may be tremor at rest, but usually it's in the later stages. I know this is too small to read and we don't really need to focus on this. There are a number of different drugs that have been used for essential tremor, mostly called beta blockers, such as primidone and propranolol. These medications and some other similar medications have been used. And they are very useful, particularly for people with mild to moderate tremor. But when tremor gets quite severe, they really don't help, or they only help blunt the tremor a little bit. And the other problem with some of these drugs is they can have significant side effects. Many of you may know that beta blockers can decrease blood pressure, can cause trouble with dizziness, can cause trouble with sexual function, can cause trouble with depression. In other words, there's lots of things that can occur with the beta blocker treatment that may not be a good trade-off for what the benefit you're getting. And one of the things that sometimes we think about is not only trying to make the person's tremor better, but also trying to get them off these medications, which is equally helpful in some cases. And so only about 30 to 50% of patients will receive great benefit from these medications without some side effects. So that's obviously brings up the topic of what would be the best treatment we can imagine for essential tremor. Well, it would be safe. That's important, as safe as possible, because I recognize as a neurosurgeon, not everything I do is safe. That's true. Effective, it would work. It would be minimally invasive. It would, of course, impact the tremor, and most importantly, improve the person's quality of life. That's what we're after here. So you want to take someone, and probably a little bit small to see in the back, but you want to take someone with a severe action tremor where they have trouble, and we use these spiral diagrams to evaluate how severe someone's tremor is, and you want to take it to something where they can write clearly, with much better lack of tremor. So I want to talk about the first form of treatment that came out for this that's surgical, and that's called deep brain stimulation, or DBS. And that was FDA approved way back in 1997, during the time that I was entering this field. And DBS has been around for quite some time. And what DBS is a surgical procedure that places a small electrode, kind of like a spaghetti noodle size structure, into a deep brain structure, and I'll show you the structure in a moment. And the concept is that electrode is then connected to a battery, and we can stimulate and adjust the stimulation of the brain to reversibly alter the function of the tissue. So depending on where the target is in the brain, we can control various things. In the case of tremor, we can control tremor with the stimulation, and it's connected to a pacemaker-like device or battery in the chest that's implanted in a separate procedure. This is done in coordination with neurologists who are expert at DBS programming, and the programming of the stimulator occurs in the neurology clinic. The important structure that we're talking about, whether we're talking about DBS or when we talk about the ultrasound procedure in a few minutes, is called the thalamus. It's a structure that's located, you can see it kind of in green here. And that structure, there's actually one on each side of the brain. And particular part of that structure, which is listed here called the VIM, or ventral intermediate nucleus, is this very important structure because we know that the tremor, in essential tremor, the circuit goes through there. So we're talking about interrupting or disconnecting the circuit going through that structure to help the tremor. In the case of DBS, we interrupt it with electrical stimulation to sort of desynchronize that area, kind of block the signal coming through. In the case of ultrasound, we're actually lesioning or causing us focal damage to that area, and I'll describe that in a few minutes. But either way, it's the same target. And so let's talk about how DBS works. DBS has multiple parts of it, but we get an MRI to show the target. That's done before. And then the procedure is done in a sort of a twilight anesthesia where we place a frame. In all of these procedures, there's a frame placed on the head, and that's so that, very important that the head doesn't move even 1/10 of a millimeter during the procedure, because we have to target very specifically. And we place the electrode, and the patient is then awakened during the procedure to test the positioning of the electrode to make sure it works for the tremor. So we have a person awake for about 15-20 minutes just during the middle of the procedure. They're not feeling any pain. The brain has no pain receptors itself, and everything on the skull is numbed up. So the person's comfort is the most important thing going through this. And at a later stage, the implantable pulse generator or battery is implanted. This kind of shows what we do. We kind of do these so-called spiral diagrams where the person has a lot of tremor, and you can see before, and then once we've stimulated the correct target location at a proper level, person can, you do the diagrams quite well. And it's a way that we use to test during the procedure. And we also do things like drinking from a cup. So we try to mimic important activities like writing or eating drinking during the surgical procedure to make sure we're in the right spot. And there's it's a little dark on here, but basically we get a postoperative CT to confirm that our electrode's in the right place. And ultimately then the whole system, it consists of the electrode and the extension wire and the battery. All components are under the skin. It takes about 2 weeks to heal up. I should mention one other thing. This shows just one side, but we can do both sides separated by a week, and therefore we can control both sides of the brain independently. So the goals of DBS in terms of the programming are to maximize symptom suppression, in this case tremor. DBS is also used for Parkinson's, which is a whole separate topic, but in the case of tremor, we're just using it to knock out the tremor. And it's quite effective. So we have studies dating back years now, because DBS has been around quite some time, that DBS is highly effective in the range of 75 to 90% elimination of the tremor. And of course, the DBS is adjusted separately on each side. So the left brain, interestingly, controls the right hand, and the right brain controls left hand. So we can adjust the DBS independently on each side, and that's done together with the neurologists. And the benefits persist. Most importantly, we have good evidence that because of control of the tremor, patients' activities of daily living improve, and most importantly, quality of life improves. So we have done this here at Orange Coast in our center since 2011. And this is just one of our early patients, Pat. She's been a nice ambassador for us. She's actually taught a lot of people about this over the years and been a wonderful person to work with. But that's also been called the brain pacemaker. So we've been doing that. I've done hundreds of those procedures here at Orange Coast, and we offer that procedure. Now, there are risks of any surgical procedure, of course, and so just to mention briefly some of the risks. We have the risk of bleeding. Fortunately, it's not very high, but it is very scary, so that anybody going through this, we have to minimize the risk of bleeding, so we minimize things like blood thinners and have people off of those before this procedure. We have slight risk of infection until everything is healed up. We used to have more trouble with the DBS hardware failing, but the modern systems are a lot better than they were 10 years ago. I've been in this field now for about 15 years, and so we have much better hardware. And if the stimulation is off, you can have trouble with balance and tingling and things like that. But most often that's just adjusting the programming can get rid of those side effects. I want to talk about the next type of treatment, which is very different. Again, same goal, which is to get rid of tremor and improve people's quality of life, but completely different form of treatment. And that's what we have been pioneering. Well, we didn't pioneer it, but we are the first center in Orange County to do this, and that's MRI-Guided Focused Ultrasound. And the MR-Guided Focused Ultrasound program that Teresa mentioned, we're thrilled that we've been doing this since 2020. I'll just tell you briefly, it's remarkable that some of the people at the back of the room, who I'm going to acknowledge later, helped us set this program up over the pandemic. So talk about doing something positive over the pandemic. This is, I think, a great way to spend your time when a lot of things were shut down, to set up this program. So that's a picture of me, so that's not that important, but this is the MRI, and one of the huge investments that this hospital system made, thank you very much, was for the MRI-Guided Focused Ultrasound. Here's the focused ultrasound, and I'll show you how that works. It's specially outfitted in the MRI for an ultrasound transducer. And then, let me explain, and then I'll show you some videos. So it's been FDA approved now to treat both essential tremor and also tremor-dominant Parkinson's disease. That's just the shorthand for that. There's no incisions, no implants. It's done in the MRI now, not in the operating room. It's the same target. Like I was telling you, the VIM thalamus. Left VIM controls right hand and vice versa. In this case, the MRI shows us the target, but then the focused ultrasound beams, which I'll show you how that works in a moment, are going to intersect and meet in the target and actually cause a thermal damage, basically a little thermal lesion, right at that target point in the brain, but not damage anything else. And that's the brilliance of the physicists and engineers that worked this out, that you can do this through the skull. Not through everybody's skull, but through most people's skull. We'll come back to that point. And the idea there is, again, that you're cutting the tremor circuit at that level of the VIM, which then accomplishes as you'll see, greater than 70% reduction in the tremor. This just shows the schematic again. I'm going to show the actual video here. So the patient is in there, their head is in the frame, everything's completely numbed up. Most importantly, the person's comfortable. We do have to shave the head completely for this procedure, which is actually kind of important. And for some people, that's a deal breaker, but for other people, it's like, it doesn't matter. And we have a wig program here, which is somewhat unique on the West Coast. But anyway, this beams of ultrasound then meet in the target, you can see there. And then we give what's called sonications, meaning the beams of ultrasound, and then bring the patient out and test whether or not the tremor is improved. So we have the online testing, in other words, after each delivery of ultrasound energy, and then we can bring the patient out and see how they're doing. And we can therefore individualize the level of treatment to that person's brain and that person's skull. So this just talks about preparation, planning, targeting, testing, and treatment. These treatments take in the range of about an hour and a half, a little bit more or less depending on the person's anatomy. But there's all this setup time, like the person comes in, they have the IV placed, we give medication to make them comfortable, we do the shaving, we place the frame, we go into the ultrasound or the MRI suite. There's a cap that goes over the head. It's ultrasound or like a swim cap. There's cool water circulating over the surface of the skin because otherwise the ultrasound beams could heat up the skin. So you want to make sure you're comfortable. So all of these things are part of the process. And this shows that's actually one of our volunteering people just to take a picture. That's not a real patient, but just to show you the system. And the key part is that after we bring people in and out of the scanner, we can test the tremor so we can see whether or not we're hitting the target. I want to give you some examples of how this works, or patients that have been treated. So here's a gentleman that we saw back in 2021, soon after our program was started. All the way out there, just hold it right there if you would. And we see his tremor comes out at the end of the movement there, which is typical. That's what we're going after. We're going to try to quiet that down today, okay, sir? Go to. And I'm going to just show you the post-procedural video. Have a look at your hand here. Look at that. I'm moving more than you are. Well, we're about the same. Look at that. And I'm a surgeon, too. I shouldn't move that much. Look at that.
Amazing.
Okay, sir. Awesome.
Look at that. Oh, wow. You know, it's
Just like,
look at that.
look at that. I can hold a glass. I can hold a glass.
Wow. All right.
I can hold that cup.
He couldn't do that previously without a lot of tremor and spilling of water. Sometimes we see patient videos in the preoperative situation where they literally are spilling water because of severe tremor. So that's what's great about this. When it works really well. What we also do is we get an MRI scan the day after this procedure, and that's actually shown here, where you see a little Cheerio right at the site of the lesion. That's a report card for me. I consider it the surgeon report card. The surgeon, basically, we need to know that we hit the target, so that's what this shows here, and that's a confirmation that we're good. Let's see if this works. One of our patients that had severe tremor, you can see how difficult it is to write. Here's the actual procedure with the actual patient. And we're all comfortable, that we do the targeting planning here. And then we deliver the beams of ultrasound, and then after the procedure, you can see your spiral diagrams are much better. Whoa.
Yay.
That's incredible. Look at that D.
I got my name back. I have to go back to the DMV and redo my license. Look at that!
This would be a typical level of tremor, so pretty severe tremor, someone who just normally cannot write well, as an example here. And then we start delivering. the beams of ultrasound, and we ask Larry to see if he can start to write, and we keep delivering, and then at the end of the procedure, you can actually see his fine motor in the hand is dramatically better. So that's what we're looking for in these procedures. We try to get at least 70 to 80% control of tremor and minimize side effects, which we'll come back to in a moment. And again, we get this postoperative MRI to show the target. Here's another patient where, again, starting out, very typical moderate to severe tremor. And by the way, we want to treat moderate to severe patients. We don't want to put patients with a small amount of tremor through the risks of a brain procedure. So we're talking about moderate to severe tremor. This would be moderate to severe. And you can see then after treatment, we give a little bit of ultrasound to see if we're in the right place, and we know we're in the right place. And then finally at the end, you can see that he's got his cursive signature back and really good spiral diagrams. So that's what we like to see in all cases. And again, we get the MRI scan. I'll probably skip through the actual outcome or the literature studies, but I'm more than happy to provide the details of these to everybody who's interested. This is such a fascinating field because there were a number of studies in 2013, 2014 by some neurosurgeons, notably at the University of Virginia, a person by the name of Jeff Elias, who's one of my heroes in the field. Happened to meet him personally, and he's a very generous person about telling me about his experience. He's probably the single most experienced neurosurgeon doing this in the United States. And he and others were involved in this initial clinical trial, which is very important because it led to FDA approval. So the FDA approved MR-Guided Focused Ultrasound for Essential Tremor in 2016 on the basis of this trial, published in the New England Journal of Medicine, of 76 patients where it was dramatically effective in relieving tremor. Of note, there were side effects, such as temporary gait disturbance, numbness, and in some patients, those persisted. I'll come back to the side effect risk in a minute, but clearly the influence of this working led to the FDA approval. There are now 5-year outcome data. This was published in 2022. One of the questions is, does this last, or is it just last for a few months? So this shows that it lasts 5 years in most patients. We don't have information longer than about 5 years in this because this field is pretty new. But that's somewhat comforting to know that in most patients, there's at least 70% control of tremor that persists at 5 years. In other words, it would really be a problem if a lot of patients had recurrence of tremor. Now, to be honest, in our center, we have seen some patients come back with tremor recurrence, which is a concern. And then we can offer either retreatment with more ultrasound or with the deep brain stimulation. So we have options for anybody with recurrence of tremor. But again, we try to knock out as much tremor for as long as possible with this procedure. And this suggests that the 5-year outcomes are still quite good. There is one other thing I should mention. This is a unilateral procedure, meaning it's just done on one side of the brain, which is different than the DBS where it can be done on both sides 1 week apart. And so studies were then done, which have now led to approval for the second side. So there was a study done, which I know that's too small to read, I apologize, led to approval in December of 2022, so just over a year ago, December of 2022, for approval of second side ultrasound. So what that means is that if you've had focused ultrasound treatment of one hand, and our patient and friend who is going to talk later today will tell you about that, you have the option then of being treated on the other hand. The way this has been done is 9 months later. So for the reason why, so because the FDA approved this at a 9-month or later second side treatment, that's where we are. We have now treated, I think it's about 11 patients now on the second side, having treated about 135 on the first side. So there's the option to treat the other hand if you have bilateral tremor. Let's give an example of a patient that we treated where we started with the right hand back in November of 2021. And here's his, and by the way, all of these patients, needless to say, have kindly allowed us to use their information, and you'll see their names up there. So this is very careful that we're not violating anyone's privacy. They've kindly offered to let us show this information. So this is his spiral, at the beginning, before the right-hand treatment, that same day in November. And you can see at the end of the treatment, he's got much better control over the right hand. So he was pleased with this, and about, now, in fact, in between the time that we treated him, the FDA approval came out for the second side in December 2022. So we could then reach out to him and offer the second side, and that's exactly what happened. So that was, this is after the first treatment. This is that MRI that we look at. The second treatment was about 7 months ago now, for his other side, his left hand. And here's his left hand. So you see, he's now got good control over the right hand, which isn't shown here because of the first procedure, but his left hand still has tremor. So we haven't really improved his quality of life as much as potentially we could with both hands being treated. So here he is after the second side, which is great. So now he's got control over both right and left hands. And here's the MRI. What's interesting also is you'll see the new lesion here, but you also have, you can see that, the old lesion here. So that little dot there is not an artifact. That's what we did in 2021. So we get good confirmation on the MRI of what the ultrasound treatment is doing. Am I being equal, or am I doing them too much? Sorry, my fault, sir. Okay, let's talk about risk. So we do have risks, and I want to be very clear about this. So even though it's not surgery, it's not an incision, it's outpatient, it's MRI-based, doesn't require implants, doesn't mean you need battery changes. So all the advantages that it has over the DBS in that sense, it's also a lesion. So it's also creating some damage in that part of the brain. So we're very careful as much as we can be to only touch that area, the tremor control, and not have side effects. But we know, and centers around the country know, that there are side effects such as change in taste, change in balance, speech, numbness, and recurrence of tremor. Now, thank goodness, for the most part, these are temporary if they occur, but it's certainly something we have individualized discussion with each patient. Probably the most troublesome one that we've seen that doesn't go away in some patients is the balance. Now, with balance, we have almost everyone it goes away, but if someone has, in our experience, if someone has some pre-existing balance problem, it's troublesome because we don't want to tip them over into having to need a cane or a walker. Most often, we have temporary unsteadiness on the feet, and that's temporary from brain swelling, and the person gets better. But we certainly have seen patients where their balance is affected for several months. So that's sort of the biggest issue. We've made some adjustments in the early part of our center to try to adjust the brain targeting for balance, and other centers have done that as well. But these are the outcome data that we have. I want to briefly mention tremor-dominant Parkinson's. I recognize it's a different topic, but it's also FDA approved for MR-Guided Focused Ultrasound on the basis of a study that came out. And again, not to go through all the details, this is not as many patients, just 20 patients treated and 7 sham patients. Parkinson's disease, which is a completely different condition where we talked more, it's about the resting tremor and other things. If it's tremor predominant, meaning the biggest symptom that person is having of the Parkinson's is tremor, then we can also use the ultrasound to treat these patients as well. So I think I'm going to skip over that for now and get into some of the frequently asked questions, and then discuss and introduce you to one of our patients that has had this done, and then to have a nice discussion. So one question that comes up, and a really important question that we talk to people about in the clinic all the time, how do I know, am I a candidate for non-medical, meaning surgical treatment of tremor? And that would include either deep brain stimulation or MR-guided focused ultrasound. Well, one of the things is obviously the severity of the tremor, needless to say. If your tremor is pretty well controlled on medications, or you haven't tried medications, then of course there's plenty of options there to look at before going down this pathway. But patients that have essential tremor or tremor-dominant Parkinson's and moderate to severe tremor that's either unresponsive to medications or the medications have severe side effects, and it most importantly is interfering with your quality of life. So for example, I mean, we've had patients that are guitarists and they can't play music because of the tremor, or they might be a potter and they can't make the pots, or they might be an artist and they can't draw, and they just want to get that back. So this is the thing, if the medications don't do the trick, we're here to look at these options. Another really important question that comes up, most really important issue for us. Am I a better candidate for the DBS, which is that procedure FDA approved since 1997 with the implant and the battery changes and the programming and the neurology? Or am I a better candidate for MR-Guided Focused Ultrasound, this newer treatment, incisionless, outpatient, MRI-based? And we are more than happy to look at individualizing this discussion around each person because it is based on many factors. And I'm about to show you a large table that we may or may not get into every detail about all the factors that go into whether an individual person is better candidate for DBS or focused ultrasound. But the key point in my view is that it should be individualized in each case. So that's the big table. And I'm happy to share this with people as well. But I'll give you some examples, and it's probably too small to read all of that back there. But these are the FDA approvals for DBS versus ultrasound. In terms of bilateral, so some people may have tremor on both sides. So in the case of DBS, yeah, you can get treatment pretty much of the same of bilateral staged over a couple weeks. We do one side of the brain electrode and then the other side the week after. And pretty much after the DBS implant, you can be treated bilaterally for both sides. And by the way, the neurologist then adjusts the stimulation one side and the other independently. And your tremor may be worse on one side than the other. And the neurologist can adjust one side higher up and lower up than the other. In the case of ultrasound, the treatment is unilateral, meaning one side, but then you can do 9 months later, you can do the other side. So these are the type of things, both of them are quite effective. Midline tremor is interesting. So sometimes we get patients where, well, I get that this might help my hand tremor if I do this ultrasound, but is it gonna help my head tremor? Is it gonna help my voice tremor? And there's more information there on the DBS where you can adjust both sides and to get rid of what we call midline tremors. That information will hopefully come out more as things progress with the ultrasound, but most likely will require bilateral treatments. The risk profile is very different, as we've discussed. DBS is really a surgical procedure. It has surgical risks like bleeding and infection. Ultrasound is a radiology-based procedure, but you are causing a lesion. So those are the comparisons there. The follow-up is very different. For DBS, you have a constant or recurrent follow-up for programming and battery changes. Battery changes these days are not so troublesome. It used to be every 1 or 2 years. Now it's usually at least 3 to 5 years before batteries need to be changed, and that's done in an outpatient procedure. In the case of ultrasound, there's no follow-up routinely needed unless, of course, there is some type of side effect or rehab that needs to go on. Sometimes we'll have people do balance therapy and things of that nature. Cosmetic aspects. In DBS, you don't have to shave the whole head. Shave up on top, shave behind the ear. And then there's cosmetic aspects. There's a couple bumps on top of the head. There's the wire coming under the skin and goes down to the pacemaker battery. With ultrasound, there's no wires, no implants, but the whole head is shaved each time you do it. So those are some of the differences. There are some important issues, like, for example, people who have pacemakers. Well, the MR-Guided Focused Ultrasound treatment is in the MRI scanner, and so the pacemaker has to be MRI compatible. For example, even today, we had a patient where we had to put the pacemaker into MRI safe mode in order to be able to do the procedure. Patients who can't stop blood thinners are not good candidates for any type of surgery, so there's considerations like that. And the anesthesia, if you can't undergo anesthesia from a cardiac or a respiratory standpoint, then DBS is probably not an option. So these are the types of things we think about in individualizing the treatment. One of the things I think, just as an overview point, I think the great part of our center not only the staff that are standing there at the back, but also the fact that we can offer both. We are really unique in being able to offer both of these procedures and individualize the therapy. In this county, we are the only one offering both. A couple more items, and then I want to go to our patient. Is there a screening test to see if I'm a candidate for ultrasound? Yes, there is. It turns out all of this in this room have different skulls. My wife thinks something about my skull. But the main thing is that our density is different. So you and me, we have different skull densities. We don't know what it is until we get a CAT scan, CT scan. We do that routinely here for screening. So if anyone's interested in this form of treatment, we can get first of all, see you in the clinic, talk about it, see if you're a candidate. We get a screening CT, and skull density ratio, SDR, has to be actually above a certain amount. So your skull has to be dense enough for the procedure. Turns out if your skull is not dense enough, in other words, there's too many holes in it, then the beams cannot focus in on the target. So just from a physical standpoint and an engineering standpoint, we have cutoffs for this. The good news is the vast majority of the population will be candidates for this, but we have to get the scan to see if they are. And then the last question, or one of the other issues that people address is, well, why the heck do my whole head have to be shaved for this ultrasound procedure? It turns out that the beams of ultrasound come through the skin, the scalp, and the skull, but they would be deflected by the hair. So we don't have to shave, mustache, goatee, beard, or anything like that, but everything from the ears up has to go. And we have to make that very clean shaven for this procedure. Okay, so to summarize, both of these types of treatment are very effective in tremor control, but they have very different sort of indications and side effects. But I think that everyone with tremor deserves this individualized type of consultation. So with that, I want to mention a couple things. This is a team effort. In particular, I want to mention these three folks who are standing at the back. Angie, right there. I cannot exist without Angie. Teresa, and Aaron. And by the way, the other Aaron, Hotrishin, thank you for supporting our program. And Beth, thank you for supporting everything we've done for many years. So those folks sitting back there are like critical to everything. And standing, sorry. And we have now done 135 procedures. This was just the celebration we had when we had done our 100th procedure. And on a more serious note, I want to acknowledge my dear departed friend, Cindy. Cindy was the head of radiology and imaging services in the breast center here for many years, and she recently passed, but I just really wanted to use this time to acknowledge Cindy and her unbelievable dedication to this program and what she has done administratively. And so it's with a heavy heart, but I want to acknowledge her in this context. With that, I want to provide you some potential websites for reading material or other things of interest. And now I want to open it up to questions, but first I would like to thank our friend and patient Lloyd. Would you come up, please? And Lloyd, thank you for doing this. Lloyd has recently been treated, but I'm going to let him tell you.
5 weeks ago, I could not hold this microphone like I'm holding it now. It just goes to show you what the FUS will do in 1/2 of your brain. This is not this half here is not the one it was operated on. It was this half. So there's a huge difference in the outcome. And I feel so indebted to this practice, this medical practice now, that's one of the reasons why I came here tonight. I also thought I might learn some more by coming here and listening, which I did. I have a lot more questions now for Dr. D, but At any rate, it was a thrill to come out of the surgery and be able to do things like this, where I was having trouble holding a spoon, or I just had a beverage a little while ago, holding it with my right hand, steady, like this. It's incredible. This one, scheduled for 9 months, thanks to Angie. That'll be next September 18th, when we'll do the left side. Yes, sir.
Since that was a tremor at rest, do you have Parkinson's?
No, I don't have Parkinson's. I've had this tremor. I first noticed it when I was about 15 years old. So it's been 65 years that I've had tremor.
Because you mentioned that essential tremor was a tremor of motion, and this is obviously a tremor at rest.
Excellent question. What the gentleman in the front said, it's an action tremor or is it a rest tremor? At the later stages, it can be both. So the fact that he's had it for decades, it's actually now partially a rest tremor. But can you do this, Lloyd? Can you just reach out maybe with this and just show? Sorry, you can actually see how severe it gets with action. Do you mind showing?
A lot of it is anxiety.
I'm sorry, anxiety. My fault, my fault. I'm asking him to do. Try the, can you show the right hand? Let's just, okay. And then go out and back and just as if, this is, now, but if you reach out with that left hand, I just want them to see how severe it can get. But holding this, and then bring it towards your mouth as if you're going to drink. Do you see how severe it can get right up there? And that would cause problems with what activities? Any type of drink?
Eating. Eating is a biggie. Like I say, the breakfast spoon that you use for your cold cereal or your hot cereal, it was getting to where it was getting ridiculous. And it wasn't always that way. It's a growing, increasing, for me, it increased as I got older, and especially this last year. And that's something I don't believe I told you even, but that was the case.
Thank you, Lloyd. I'd like for everyone, thank you so much for doing this. Can you explain, well, I want to get more information out of him before I let him sit down. Can you explain the procedure a little bit, just from your standpoint? Because it's easy for me to show pictures, but just what it's like from the patient's standpoint, the head shave, the frame. Because, I think there's a lot of fear, and normal. You're going through a brain procedure. It is in the radiology suite. It's not in the operating room, but you are getting the head shave, the frame, the injection, the cap, the cool water, the noise of the MRI. Can you kind of go through all that and just describe that process a little bit?
First off, let me tell you that I have a Christian missionary friend who lives in Florida who was telling me by email on October 11th about this new procedure called focused ultrasound. She heard about it in a community-wide meeting that she went to the night before. That was October 11th. I had my surgery, my successful surgery, here on December 18th, 2 months. Be steady. 2 months. It's just amazing for me because that provided the relief that I needed from this dirty thing, essential tremor, that I'd never known. Let me also tell you that when I was about 40 years old, I was prescribed some beta blocker. And I've been using that for about 40 years. And my feeling is the beta blocker isn't always going to be successful for your extended use, but for me it worked for 40 years to a certain degree, and that was very helpful. Now, concerning the procedure itself, it's a 2-month-long issue. It starts with the first meeting, I think it was in early November with Dr. D. And then you do have to come here early in the morning to have your head shaved. I've never seen myself without hair, but this is 5 weeks worth. And you're shaven, and I didn't care for that. I'm a vain person. Well, that's how I remember that I was about 15 years old when I first realized I had tremor, because when you're going through that stage of puberty, You're aware of everything that makes you different than other people.
Right.
And that's one of the things I experienced was the essence of tremor. Back then, they didn't call it ET. They didn't have a name because it didn't exist. But nonetheless, I found out a lot more about it about 40 years ago, and I started taking the beta blocker, propranolol. As far as the procedure is concerned, you come in, your head is shaven, you're taken from one building to another, and you're set in a machine that slides back and forth, as you can see from the video, and so the doctors can take readings and adjust the machine properly. What else is there?
Any pain at all?
Noise.
Any pain and noise? Pain and noise.
No, the noise is kind of a problem, but they played classical music for me, which is fine. That's the way I like it. And that, they tried to drown out the noise. Every kind of beat, rhythm that you can imagine, they put through this MRI. And so you get to listen to that for about, in my case, it was an hour and a half, just like you said, before the procedure was completed. So the procedure may not be for everybody because it is a little intimidating, but for me, it was an experience. And it was an experience that I loved because I could see there was going to be some positive results. I just knew it. Yes, sir.
How much is that?
I'm sorry, say that again?
I was wondering how much the purchase of that.
How much does the procedure, I didn't hear the last part.
How much does it cost?
How much does it cost? Oh, that's not a question for, no. Insurance covers the procedure, Medicare covers it for the approved indications, which is, like I said, essential tremor and tremor-dominant Parkinson's. So it's covered completely by insurance. So beyond that, you'd have to look at individual insurance plans about copays and all that type of stuff that nobody wants to think about. But we have experts who do this all the time. Can I ask a little bit of a follow-up question to Lloyd? So did you have any immediate temporary side effects? One of the things we very often see is some temporary imbalance for a few days, sometimes some tingling in the fingers or face. Did you have any of those, and if so, how fast did those resolve?
I'm not aware that I had any side effects at all. I'm not aware. That's not to say that I didn't, because I could have had things that I was not aware of, but there were none, and I fully expected something to be different. After all, this is a brain procedure, but I'm not typical, I imagine. Maybe you could speak to that.
Your voice was fine?
Yes.
Taste was fine?
Yes.
No tingling or numbness? No imbalance? So there definitely are people that will have those issues temporarily after this procedure, and so we talked to everyone about that, but I'm very pleased you have no particular side effects. And go ahead.
There was one thing, when they shave the head, before they put the gadget on your head for adjustment, for focus, they have to numb the 4 areas where the pins are going to screw down to your skull to hold the thing in place. And that numbness, that anesthetic that they install in those 4 locations took a while to wear off. That's the only thing that I could see was a downside. For me, it was about 8 days before it was completely worn off. In that amount of time, the medication gravitates down around your eyes, and so you have puffiness and actually a decrease in your field of vision, in my case, because of the puffiness around my eyes. But that was very minor.
Thanks for mentioning that, Lloyd. That's absolutely common too. Very temporary swelling around the eyes because we put in a ton of anesthetic. In your case, obviously, we put in a ton of anesthetic.
I think you did.
And that's because we want people to have zero pain But it is absolutely true that it can be numb for quite a while after. But we prefer that to pain during the procedure. But we appreciate that puffiness or swelling is different in everybody. But we certainly have that. It's all temporary. Yes.
Lloyd, we really appreciate hearing your first-hand account. It brings it home to us. I'm wondering how many times you went back and forth into the machine before the procedure was complete.
Dr. D can probably tell better than me, but as I recall, there was about 3 times. I thought it was going to be more like 20 or so in order to get the right readings, but no, I think we went in and out about 3 times.
Yeah, it's a great question, and I'd like to explain that a little. It's in the first sonication where we're just testing to see if we have the right spot in the brain, and we're testing out the temperature. We do what's called a subthreshold sonication. In other words, we deliver the beams of ultrasound, and we're able to see on the MRI right after that, where we have him in there, where that spot is hitting. And we overlay that with the target volume, and we make sure we're in the right spot. So there's a couple little setup times like that. And we also check different planes. For example, we want to look at right, left, we want to look at front, back, and we want to look at depth. So like anything, it's 3-dimensional coordinates. And so we do 3 what's called alignment sonications. So everyone's getting that. And then if all of that looks good, and it did in your case, then we hit the treatment, because we know now we're good in all 3 planes. And then we hit the treatment temperature and look at the tremor. So, and do you remember doing the spiral diagrams?
Now that you recall, yes, we
Okay.
did do it during the procedure.
Yes.
During the MRI procedure, we did a spiral.
And we'll do just like we show there. We take all of those different spirals in between. Yeah, any other questions on that? Yes, sir.
I don't know if he was claustrophobic, but what do you do in patients who are claustrophobic?
Yeah, it's a great question, Doctor. Thank you for asking that. Claustrophobia is a big problem because you can't have people sedated for the procedure, because if you're sedated, then you don't have the tremor. So it's this kind of catch-22 where we make people comfortable. We can give Tylenol and a little bit of fentanyl, but we just for the pain or the frame, but we have to have them awake for the tremor testing. So severe anxiety or claustrophobia is kind of a relative contraindication to this procedure. And in fact, in those cases, DBS is a little bit simpler because they're not in a magnet. So if someone's so claustrophobic that they can't even get an MRI without Ativan, then probably we can't do this, because it's literally an hour and a half in and out of the magnet. In fact, that's another screening that we do. Yes? Yes?
You're going to have the second procedure done for your other side. Are you still going to need to take medication at that point, or will you be off the propranolol?
If once after the second procedure is done, if it's as successful on my left side as it was on my right side, I won't be taking any drug.
Okay.
I don't care for drugs. I don't even like aspirin.
Right. But you're still taking it right now, though.
Yes, I'm taking propranolol. Hopefully it'll decrease my tremor in my right hemisphere.
It's a great question. We usually still have people on medication until both sides are treated. Yes?
Nothing to do with the procedure.
Right?
Oh, I'm sorry. Let's just gentleman here first. Go ahead, sir.
This has nothing to do with the procedure, but do some people with essential tremor respond to alcohol? And if so, is it a problem?
Just so to repeat that in case other people didn't hear that or on the Zoom, gentleman in front asked, do people with essential tremor respond to alcohol, and if so, is it a problem? It's a great question, because it turns out that the answer is yes. Most people with essential tremor, if they take some alcohol, and there's actually been studies on this with dose dependence of alcohol, the tremor will go away. The question is that a form of treatment, or is that just masking it? Most of us think that's not really the best way to treat it, but in fact, it's almost a diagnostic thing. So I ask people in the clinic, have you noticed if you have a glass of wine or a beer, and they'll say, oh yeah, I have a few drinks and is gone, but I can't use that at work, you know. And so it's an important point for almost diagnostically, but we of course don't use that for treatment. Go ahead, sir, back here. Yes, sir.
Okay. As you mentioned that you have 70 to 80% success rate. And also you mentioned the side effect of those 3-4 things. Besides that, you have any severe side effect of just like losing the control?
Yeah, it's a good question. We're talking about the ultrasound procedure now? Yeah. With the ultrasound procedure, I would say we're pretty clear on balance being an important issue. We certainly don't want to cause a permanent problem in balance. And then tingling or numbness, speech and taste. Now on the speech and taste, I want to kind of clarify that for people. We've had a number of patients that have had temporary speech articulation problems, meaning like slurred speech. And we've had a number of patients with taste issues, meaning reduction or alteration in taste. Thank goodness on those last two, because speech and taste are really, really important quality of life issues, of course, speech and taste. Thank goodness on our unilateral, our first side patients, we have, and Teresa, correct me if I'm wrong, because you know even better than I do, almost all of those have resolved. The speech at its worst has taken a few months in some patients to resolve completely. Again, that's a rare side effect, but something we see.
Process for that one?
Say it again?
You go through another process of that ultrasound to get it resolved?
No. So we're talking about the risk of the ultrasound procedure, then something where we might have to give some speech therapy. In a few cases, we've had to do some speech therapy, but then it has resolved. The one where makes us nervous, meaning that I don't want to even do the procedure, if someone has a pre-existing balance problem. For example, let's say someone has Parkinson's or they have tremor, but they have a balance problem and they're swaying on their feet already, and we can test that in the clinic. Sometimes even over Zoom, we can test a little bit. Then we have a situation where we don't want to make that worse even temporarily because we don't want that person to fall. So we occasionally then have to coordinate with the neurologist. So to answer your questions about what are the most severe side effects we've seen, it's really been on the balance. Now, you might think, oh, is there a risk of stroke? Is there a risk of weakness? Is there a risk of personality change? Is there a change in your IQ? Those level of things we have not seen at all because it's such a focal treatment. So I would consider imbalance and ataxia, meaning more difficulty moving, a significant side effect. That, to me, that's a significant side effect. So we try to avoid that as much as we can.
Explain me that again, what do you mean by 70 to 80% success rate?
Oh, okay. Right, so we're talking about 70 to 80% tremor control. So in other words, we don't cure this condition, but you can see when you look at the spiral diagrams that the person's tremor is down to a fine tremor. So the tremor goes from something like, Lloyd can describe this, the tremor goes from something like this to something much more manageable. In his case, I would call that 80 to 90%. But we're not saying that we're knocking out the tremor completely. It's just 70% or more is the target goal. And mostly that's because once you get the tremor down to a fine tremor, you can do things like, use your hand. So I hope that clarifies it. Yes, sir.
How easy is that to talk other parts of the brain?
I got the last part, parts of the brain. What was the first part?
How easy is it to talk other parts?
How risky is it to the brain? Am I missing that?
How easy is it to talk other parts of the brain?
I missed that. Did anybody get all that?
How risky is it to other parts of the brain?
Other parts, thank you.
Yeah.
Is that what the question is? How risky is it to other parts of the brain? Yeah, not risky. That's the key. It's risk to that area right around. The reason why, let me explain that a little bit better. The reason why we have some risk of tingling or numbness in the hand or face is that area of the brain is immediately behind the tremor control area, so it's right on the border. So if we have a little bit of swelling, like you saw on the postoperative MRI, there's that ring. We can have a little bit of temporary tingling or numbness in the hand or face on that side. It's because that area is right next to the tremor control area. So that's something we see very frequently. But most often it's temporary. Yeah, Teresa.
So similar to that question, a question from online at the Zoom.
Yes.
Zoom is,
Great question.
Does that other area develop any scar tissue?
Yeah, it's a great question. So the question was from the Zoom was, how do I prevent the ultrasound from causing any damage on the tissue in between? That's really where the genius of the engineers has come. And what happened was in the 1990s and then into the early 2000s when this was being developed, they figured out ways to have hundreds and hundreds of beams of ultrasound meeting in a target and only heating up that target. So if you can imagine beams of radiation that are meeting in a target and only radiating that target with enough radiation to cause damage, is very similar here, except that ultrasound is not radiation, it's thermal energy. So what you actually have in that picture and what Lloyd and others have gone through is there's basically a planetarium type thing going on over the head where all of those beams of ultrasound, in the case of a planetarium, it's beams of light, right? In the case of this, it's beams of sound. The beams of sound are going through the skin, the scalp, and the skull. That's why the hair is shaved, because otherwise it would be deflected. But they're meeting in that target in the brain. And that's then heating up just that spot because the beams are meeting there. It's basically they're adding up just in that spot. And that's how everything else in the brain is not heated up, only that spot. So that's the focused part. So that word focused ultrasound, that focused word is where the engineering genius has come in, and that's beyond my level of knowledge of engineering, but they can then focus it there. And that's also why certain skulls don't work, because if the beams can't be focused through a given individual skull, then we can't do the procedure because it would be too damaging to the brain around that area. In other words, if you can't focus it into a spot, then it's not safe. I hope that helps.
Lloyd, are you right-handed?
Yes. Yes, before any of this thing starts, the doctor asks you, which hand do you want to have corrected first? Well, I'm right-handed, right side dominant, I guess you'd say. And so I said, well, let's do the right hand so I can write checks again. So I can balance the checkbook and have it legible. That's where I was starting. It was pretty bad.
How big is the spot that you're focusing on?
Yeah, it's a great question. So that VIM target is about 6 millimeters, and we have to hit about 4 or 5 millimeters of that to be able to knock out that circuit. So we're talking about the size of a green pea, is how I describe it. I looked at all different vegetables, and garbanzo bean is too big, kidney bean is too big. Corn, like a little thing of corn, is the wrong shape. So in all seriousness, it's about the size of a green pea. But it is that, the good news is with the modern MRI, we can see that in every patient. And there's internal brain landmarks that lead us to that target. But then once we're delivering the ultrasound to the patient, we can test and adjust as needed. That's the nice thing about this. So, but anyway, it's about that size. And that's exactly what you saw in the post-op MRI is that little spot.
Question.
Yeah.
If over time it starts to not be effective anymore, can you go back and retreat that same area?
Definitely. The question is, can you retreat if needed? So far in our center, we haven't retreated yet. However, it is the case that we have a few patients who unfortunately have had some recurrence of tremor. Yes?
Similar question from online on the Zoom. It says you mentioned that the tremor control lasts for about 5 to 7 years. And after that, does the client go through a second procedure if the tremor comes back?
Yeah, let me kind of address that together. So back to your question. So the answer is centers that have been around longer than ours and have seen hundreds and hundreds of patients more than us have had patients come back over time. Thankfully, not most of them, but some of them where the tremors come back. And indeed, they can retreat. With retreatment, you take that MRI and you say, I want to target a little more tissue around it. Again, there are risks, but you can also you can recapture the tremor control. So that's that one. Back to this 5 to 7 years. What we have is obviously, here's the thing, of course, it's an average because everybody's brain is different. But that study that I mentioned, the 5-year study, basically said that at 5 years, 70% control is still there on average. We have seen, and Teresa, again, you have all the outcome data. We have seen a few patients where there's been slight recurrence of tremor over time, but usually not back to where it was before. So they may still have good control, not as good, but good. The moment, then we talk to them, and then the moment we follow them, and then the moment it gets to the point where they're like, this is not good, it's back to where it was, then we can either offer retreatment with this procedure or we can offer the deep brain stimulation procedure. So we have options, but of course, that wouldn't be what we would call the best outcome, but we at least can have those options later. It's in the handful of patients range that we've seen that. Yes, yes, sir.
I imagine the answer to this question, but some patients with Parkinson's disease have no tremor.
Yes.
Big problems with gait. Is there any chance of affecting a different part of the brain?
Yeah, the question is about Parkinson's, and let's say they don't have tremor. Well, you're absolutely right that Parkinson's has gait problems, rigidity, stiffness, other things that happen in Parkinson's, and we have a completely different brain target for that, so that's a different topic. But definitely DBS, deep brain stimulation for Parkinson's, has a different brain target. It's actually a little bit below the thalamus called the subthalamic nucleus, or STN. So we routinely do STN DBS for the other signs of Parkinson's, such as stiffness, rigidity, slowness of movement. So in other words, for the category of Parkinson's patients that don't have tremor predominance, then we don't use this procedure. Yes, sir. Yes.
How does a doctor determine if your tremors are from Parkinson's or from just essential tremor?
Yeah, it's a great question about ET versus PD tremor, Parkinson's versus essential tremor. The biggest dividing line is whether the tremor is at rest versus an action tremor. So, and we discussed in Lloyd's case that he's had the tremor for decades and he has a little bit of rest tremor now, but you can see his tremor is much worse when he actually reaches with that left hand now. When he reaches for an object, if the tremor is worse, that's usually essential tremor. Whereas this resting tremor that you see like this, where someone's just standing there in the supermarket, is Parkinson's disease until proven otherwise. There are other conditions. I'm not trying to say all tremor is just these two categories, because there's 5 million conditions in neurology that cause tremor, but not really 5 million, but a lot. But you're right, that's the diagnostic key difference, is the action tremor versus the resting tremor. Usually it's action tremor, it's ET. Resting tremor is usually Parkinson's, what's called Parkinsonian tremor. Yes? Yes, I'm so sorry, I didn't understand that. Did anybody get that?
Cerebellum? What about the cerebellum?
Yeah, but the 3 men not work on that. Cerebellum method. Next, I do the body feed.
Asking about treatment to the cerebellum.
Why wouldn't
it work?
Oh, okay. Well, the cerebellum is the structure at the back of the brain here, and that is involved in the tremor circuit, so you make a good point, but it's such a big structure, whereas everything then runs through the small structure called the VIM. So back to this gentleman's question, might as well interrupt it where we have it at 6 millimeters. In other words, if you think of a circuit with all the wires running into a small structure where you could just cut that small little area, that's what we're doing rather than cutting all the wires back here. That would cause a lot more side effects. That's a whole, that would be all sorts of problems with movement. Yes?
We have an online question asking if there's an overnight hospital stay associated with
Uh-huh.
this.
For the DBS, it's overnight in the hospital, which is just to make sure that people are fine overnight. For the ultrasound, no, it's outpatient. Yes, sir.
I read in here that you wouldn't do the procedure, at least it wouldn't be covered by insurance unless you had tried the meds first.
Right.
Is that still a requirement?
Yeah, that's my understanding, that at least 2 medications have to have been tried and failed, which is pretty common that people have been tried on things like the propranolol or primidone, these medications, the beta blockers, for some period of time. And that's important because we don't want to rush into it. And most often people have had this for decades. They've tried all those medications. So it's not an issue. If someone has a new diagnosis, though, we want to definitely point them towards a really good neurologist and say, you know, try all this first. Yes?
The 2 medication that you just mentioned, is that for essential tremors? Or if you're on if you have Parkinson's and you're only on 1 medication, is that you have to be on 2 for that as well?
Good question. Let me just repeat that in case the online folks didn't hear. So what this lady asked was the 2 medication requirement, that's really for essential tremor. For the ultrasound procedure, the way it was FDA approved, you have to have tried those medications. For Parkinson's disease, things are a little bit different because there's so many other medications and other things that can be going on. Okay? Yes?
Would someone that has neuropathy or some similar condition, would that prevent them from being a candidate?
Yes, the question is, does neuropathy prevent you from being a candidate? No, it doesn't. The one thing about neuropathy, though, that can be a problem, and you may know this, or many of you may know this, if you have a lot of neuropathy in your feet and hands, that can lead to balance problems. And if that person has balance problems, then we have to think about it as being a little bit more high-risk category for having more balance problems after. But if there's just neuropathy in the fingers, like tingling or numbness in the fingers or feet, and the person doesn't have a balance problem, then it's completely fine. In fact, you could make the argument it's then the actual issue of tingling in the fingers. If you already have it, you're not going to have that risk. So back to your question, the answer is no, it's not a contraindication, but we just have to look at the balance issue. Yes, sir?
Have you performed the FUS procedure on Parkinson's, Tremor-Dominant Parkinson's patients, and have you had success?
Yeah, really great question. We have just started. Let me repeat the question. This gentleman asked, have we performed the FUS procedure on the Tremor-Dominant Parkinson's population? In those studies that were somewhat recently published, although it dates back to 2018, there's only a lot of numbers recently in the literature. Not as many fewer patients with Parkinson's have gotten this than, and in our center the same is true. It's really just been a few. How many?
3.
Just like 3, but not that many. And
So Medicare didn't cover it until July.
that was the big issue with this. What's odd, and not to go down this pathway too much, but FDA can approve something, but then whether Medicare covers it or not is a separate decision. So we've had this situation for a while with the Parkinson's population where that tremor-dominant Parkinson's indication for focused ultrasound has been FDA approved since the 2018 study, but it hasn't been Medicare, it's not paid for by Medicare, it's not covered by Medicare until pretty recently, July of 2023. So between July of 2023 and now, we've treated several patients. Back to your question, yes, it's effective for the tremor. I get more nervous about that population because they have more balance problems to begin with, so that's why we have to be careful. That population also needs to be offered the opportunity of a DBS because they may have other things. So even though they may have tremor-dominant Parkinson's, if they have rigidity, if they have stiffness, then the DBS is more likely to cover those other parts of it. That is evolving. There are other targets now for ultrasound, such as the GPI ultrasound and other areas of the brain for Parkinson's. So I think that whole system will evolve. But it's very recent that it was even covered by Medicare. So basic answer to your question is we've started on that, but don't have a lot of experience yet. Yes, sir.
Yeah, how long do the benefits of DBS last compared to ultrasound?
Yeah, really great question. DBS versus ultrasound duration. You know, the DBS, once the electrodes are in the right place, which is the job of the surgeon, Then it's about the battery changes and the readjustment over time. Now, it is the case that essential tremor can progress over time and you can have more tremor. Then the DBS gets readjusted and can capture the benefit. As far as we know, at least 5 to 10 years, and probably longer, probably 10 to 15 years, you can continue to get the benefit from the DBS by readjusting the stimulation. So we have data that extends out much longer with the DBS in terms of effectiveness than with the ultrasound. So from the standpoint of, so that's another really important point. Let's say someone comes to see us and they're in their 40s or 50s, and it's not as common as people later, but let's say they have severe tremor. We generally will, at this point in time, because we don't have data more than 5 years with ultrasound, will generally suggest the DBS because they're so young, and then they can get benefit over many years.
Question.
Yes?
Where did this originate the procedure, FSU?
FUS, yeah. The focused ultrasound, I'm not the perfect historian on this, although I have an article for you because I don't remember all the details, but I'm happy to, if I get your email, I'll give you all of this. This has existed for several decades. People did this through a craniotomy in the 60s by taking off a piece of the skull and then focusing ultrasound. So in other words, ultrasound's been around a long time. The genius, and so they were doing it, but they had to take off a piece of skull, which at that point is more invasive. So it's sort of a research thing. They did it in animals, they did it various ways. Now, here's the thing though, it wasn't used clinically because you had to take off a piece of the skull. Once it became clear that they could do this through the intact skull, which is, like I said, like the 1990s to 2000s, there's a group of relatively famous people that then applied this and showed that they could heat up just that spot in the brain. That's where it took off. So it really is really an engineering triumph. And I'm going to say the name Kujärvo-Heinonen, and I may be mispronouncing that, but that's the genius engineer that had all of these papers about how to do this through the intact skull. That's the part that ultimately led to this company, Insight Tech, the one who was founded in Israel but now is around the world, basically licensed that technology and can now do this through the intact skull. So in other words, ultrasound's been around a long time, and I'm not the best historian of ultrasound, but it's been around decades. But the fact that we can do it now through the skull is the key.
And to follow on to that question, what are the new things that are going to be happening with this procedure? Will they be able to do non-motor things, say for attacking or helping anxiety, fatigue, and other things?
I really appreciate that question, sir. Thank you. So the question was, what about other things coming down the horizon for ultrasound? And you know, it's quite exciting. And those of you who have a research interest in just learning about this, I suggest you look at that top website, fusfoundation.org. They have a link to all the modern studies on this. So that's sort of a more complete answer than what I'm about to give you. But what I could tell you is it's quite remarkable. If you actually look at the current edition of 60 Minutes, many of you might have seen it, it talks about how focused ultrasound is being used to open up the blood-brain barrier. And it's the same technology, just applied differently. And that has enabled surgeons to allow Alzheimer's drugs to get into the Alzheimer's brain and be able to cause a reduction in plaques in the Alzheimer's brain. So that's a good example of a whole new use of this technology to allow drug access into the brain. There are studies in brain tumors, there are studies in epilepsy, anxiety. So just about all over the place, there's going to be interesting applications of this technology.
We had one more question on Zoom was, can you wear earplugs?
The question on Zoom, can you wear earplugs? It's pretty loud in there, right?
It's loud.
He says it's pretty loud. He has a great taste in music. You listen to the classical music.
Classical music, right.
Yes, sir.
Very
We
helpful.
have YouTube connected up to any station you like into the earphones. So you're welcome to wear earplugs, but we suggest that you listen to your favorite music and we crank it up during that time. There's MRI-compatible earphones. That's what they have over here, thanks to the radiology group. So I would agree with you. I would listen to classical music.
That was the least of my concern
Yeah.
at that point.
Yeah. Thank you, Lloyd, again for joining us up here.
Thank you.
All right, thank you, everybody, and first and foremost, thank you, Dr.
Thank
Binder,
you.
for sharing this
Thank you.
information with us.
Thank you. Thank you.